Welcome to a clinician guide to tumor treating fields as a fourth modality in cancer treatment, understanding the science and evidence, and implementing critical nursing roles in practice, featuring Ms. Madeline Couch and Dr. Surya Jayapalan, who are both from Tufts University Medical Center in Boston, Massachusetts.
During this talk, we're going to understand the science and evidence and implement critical nursing roles in practice. I'm Dr. Surya Jayapalan from Tufts Medical Center in Boston, Mass., and I'm joined by my colleague, Madeline Couch, a nurse practitioner at our institution. Maddie, can you introduce yourself, please?
Hi, as Dr. Jayapalan said, my name is Madeline Couch, and I work with her at Tufts, taking care of our neuro-oncology patients.
In this activity, we'll be reviewing the clinical evidence and nursing strategies on the use of tumor treating fields in solid tumor malignancies. So this is the concept behind it. So what's interesting about this, if you have to go back to, your high school biology and remember mitosis. And when you remember mitosis, you remember that that when cells enter into mitosis, they are entering this process where they're dividing. And what TT fields is this electrical field therapy that basically will disrupt mitosis. So the majority of the brain cells are really in this G0 resting state. And this treatment will help keep that quiescent cells quiescent, and anything that tries to divide will immediately be affected. And that's kind of the whole rationale behind this treatment. And right now, we're going to sort of see like a kind of a simulation about the mechanisms of how tumor treating fields act on cancer cells. And this sort of describes basically shows what I've just described.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death.
So part of this also is, when you're thinking about electrical field, there's the intensity and the frequency, right? So the intensity is the voltage, and the frequency in this case is measured in kilohertz. And when they were modifying electrical fields and using them in tissue culture, they were able to get an idea of what tissue, what is the best frequency to sort of adjust the field to. And it ended up being that GBMs, the best cell kill was at 200 kilohertz, okay? And the rest of this, of course, the cells in the brain are spared because nothing is trying to undergo division, so they're not trying to undergo mitosis. But in other cells, if you want to try and direct a treatment and spare cells that are dividing, because as we just talked about, the lung is always dividing, the liver is always dividing, they're always trying to regenerate themselves. They found out, taking like normal, that the frequency where you would affect normal intestine would be 50 kilohertz. But that was different for pancreatic cancer. It was 150 kilohertz. So you would have cell kill in the setting of a pancreatic cancer in 150 kilohertz, but you would spare the normal intestine. And so what that kind of is that the effects on the cells are very specific and inversely related to size. And so you can see that with adjusting the frequency, even outside of the brain, and in trying to target tissues that are dividing and trying to spare other organs around them that are also dividing too as well and regenerating, you can actually have a specific sort of frequency that will then only kill the cancer cells and then spare the normal cells. But let me take a look at some of the clinical evidence, since we're all clinicians here and we're trying to help our patients in real life situations. So glioblastoma, just to remember, it's in the news now because, of course, Joe Biden's son, Beau Biden, unfortunately, sadly died of a GBM in 2015 at kind of, at 47 years old. And then, of course, Joe Biden's friend, Senator McCain, also died of a GBM, and the McCain family was saying what a support he was to them. And of course, Senator Kennedy also in Massachusetts, which was a big shock to all of us in Massachusetts when he passed too as well from his disease. And so, it's a very rare disease. It kind of hits the consciousness because of these, people in our political spectrum that have come down with it. But it is basically a disease in the United States of white, just because of the demographics, middle-aged men. It tends to strike down people in the prime of their life, like Beau Biden. But there's a second peak in people over the age of 70, which explains actually Senator McCain and Senator Kennedy too as well. Prognosis, surgical resection, if the surgeon can come in and take out that whole tumor, that definitely helps a lot, because it's basically kind of immediate cytoreduction, which leaves a lot less for me as the treating oncologist to have to deal with. If I can deal with microscopic disease that's left behind, it's a lot easier than having to deal with something like this, where the tumor is already overcoming a lot of its barriers and is kind of out of control, and we're trying to drive it back under control. Tumor location, therefore, is very important. If the tumor is closer to the surface and not near a critical area, the surgeon is much more amenable to surgical resection. Genetics is now, everybody's talking about, targeted therapy, but we know now, based on prognostic factors, some of the biomarkers that are very important in diagnosis of the GBMs, but also in prognosis too as well. And then the end of the day, if you're good at the beginning of your treatment, the chance of you being good at the end is very good too as well. So obviously, if somebody doesn't look good, is, bed bound, then trying to get them through chemo and therapy is tough, and they have a harder time with it. And historically, poor prognosis has been, we didn't have a lot of treatment options. And really, there's been only 3 treatments that are FDA approved that have a survival advantage in about 30, 40 years of trying. One came out in the 90s, and then one came out in mid-2000s, and I'm going to talk about this latest one that's come out in 2015. And sadly, there hasn't been anything else in the last 5 years, but this really, I think, has been a big game changer because it really has helped long-term survival. So in this slide here, you're going to see that this is the NCCN, and the NCCN is the National Cancer Comprehensive Network. Their group that is designated by the NCI, the National Cancer Institute, and they basically make the guidelines for treatment of all cancer in the United States. And this is their slide for treatment approaches for newly diagnosed glioblastomas. And here you go, there's patients that are younger than 70 years old with a good performance status, and the performance status is the Karnofsky performance score greater than or equal to 60. And this is basically showing their methylation status, whether or not they're sensitive to temozolomide or not, i.e. whether they're methylated or unmethylated. Doesn't matter whether you're sensitive or not to temozolomide, you will still have a good treatment response with the Tumor Treating Fields. And as you can see right here, there's a Category 1 designation by the NCCN, which is their highest recommendation, that the addition of Tumor Treating Fields to standard of care, which would be the radiation and concurrent temozolomide, yielded a survival advantage. And this was based on the 5-year survivals from that were reported in 2018. Well, close to 20% of the patients actually in the trial were over the age of 70. And in those patients, again, the addition of Tumor Treating Fields to the standard treatment of radiation and concurrent temozolomide led to a survival advantage. And that was, again, in the setting of whether or not you were sensitive to temozolomide or not. And this is what it looks like, okay? So basically, you have these 4 arrays, front, back, right, left. There are these 9 ceramic electrodes. They're in this conductive jelly, and they're hooked up to this battery and computer device. And this thing weighs about 2.5 pounds, and you carry it in this kind of backpack. You can wear it as a backpack, or you can wear it as a messenger bag. Some of my patients who have seamstresses in their family, or they know a good seamstress, they have them make it into a fanny pack, so you can just wear it on the back, or no, kind of over your buttocks, around your waist, and it's pretty portable. And when people first look at this, I say, look, if I tell the women, look at your handbag right now, I can guarantee you that it's probably weighs more than 2.5 pounds. For the trial, the device actually wore 6 pounds. So I told people it kind of went from your Dell laptop to your MacBook Air. And this is what it is. It basically develops this low intensity voltage with this intermediate frequency for the GBMs of 200 kilohertz, like we talked. That does this electrical fields, and it's strapped into this thing. And what's interesting about this device records how much the patient is using it or not. And they need to use it 18 hours a day because this is electricity. If you turn off that switch, that electricity goes off. So if you turn off your light switch, there's no half-life, that, the room is instantaneously dark. So if you are not wearing this device, it is not working. There is no half-life. It's not like a drug or something like that. And so because of that, people are, in the trial, they wore it 18 hours a day for 2 years. And that's very important that people have to understand that they need to wear this continuously for this to work. But what's interesting is that it's recorded in this device. So at the end of the month, I get a report from all my patients, and I hear if they're wearing it 50% of the time, 75% of the time. A lot of patients are wearing it 90 plus, because their idea is, if I'm going to do it, I'm going to do it. Because there has to be a circuit. So we know if the circuit's completed, they're using the device. And so when I get that report, I call them up if they're using it less than 50% of the time, and say, hey, we could do better than this, And that's another nice thing about this trial, is that we knew people were using the device, and we knew when they were not using the device. And that's something, when you give people pills and you tell them, hey, go off and take it for 30 days and keep a logbook, you don't quite know. And you have to realize that, our patients are brain tumor patients, and sometimes they get a little bit confused when not they take medications. So I think this is one thing that's very interesting, that we absolutely 100% knew when people were using the device and when they were not. And this is what it looks like. And what's interesting is, based on, you can actually target. So you can actually shift the rays around, front, back, right, left. And it's not like, it's not like radiosurgery, but you can direct the rays into a certain quadrant. So here is the study trial design. And as you can see, this is a simple 2-to-1 randomization trial. About 700 people were enrolled in the trial, and 450 got the electrical field therapy with the temozolomide, and 250 basically got the temozolomide in adjuvant setting by itself. Everybody got the standard of care, which is the STUP regimen that was published in 2005 in New England Journal of Medicine, where they got 6 weeks of radiation combined with daily temozolomide. Temozolomide, as people know, is an alkylating agent, and it acts as a radiation sensitizer, hence potentiating the effect of the radiation, which is what we saw in that trial, which led to its FDA approval and Category 1 designation also by the NCCN. People then, they didn't want to include the electrical field therapy with the upfront radiation therapy, because they were not sure if there was going to be some interaction between the two modalities. So they waited till about 4 to 7 weeks after the completion of radiation. And that's usually about the time when we do the post-radiation scan to see the effect of radiation. Patients were stratified based on the type of resection that they had, whether they had a gross total resection versus a subtotal resection versus a biopsy. And then, of course, temozolomide is dependent on the MGM, the activity. If you are MGMT methylated, you are more sensitive to Temodar. If you're unmethylated, you're less sensitive. So that was also a stratification. And we know from the original trial, the EF11 trial that was done in recurrent GBM patients, that it takes about 8 months or so for the device to kick in. It's a very low energy device. And we know that patients can actually, recur before that 8 months happens. So they allowed patients to go on to a second progression. And that's what happened here. Whereas the control arm did the temozolomide for just the 6 months. So this was the results, and this was a landmark because, as I said, there's only been three treatments that have been FDA approved with a survival advantage over the last 30 or 40 years. And the last one before this was 2005, Dr. Stoop's original trial that was published in New England Journal of Medicine in 2005. And then this was published in JAMA. And you can see in the intention to treat population that the progression-free survival is what you want to see with the tumor treating fields was significant, and it led to about almost a 3-month improvement of progression-free survival with a hazard ratio reduction to 0.63, highly significant. And then the survival also too as well was almost a 5-month improvement of overall survival, again with a nice separation of the curves. What's interesting here is, of course, people use the device for 2 years in the trial, so there's clearly some prolongation of the effect too as well. And again, a very nice reduction of the hazard ratio to 0.63, actually very similar to what temozolomide did back in 2005 with, again, a very nice, very heavily significant p-value. And this was just something what I wanted people to see was that, everybody benefited. When they did the subgroup analysis, everybody benefited from this device. And then this just goes to show that, there was a lot of, talk about, is this going to make people psychologically feel different to have to shave their head, wear this device, carry around a 2.5-pound backpack, or in the trial it was like a 6-pound backpack? Are they just going to feel worse about themselves? And I think you can see, compared to the control arm, there was really, when they looked at everything, cognitive function, emotional function, physical function, role functioning, social function, people were just the same as they were. And there was really no difference, okay? And I think that's something that people have to understand. Again, don't be the person that makes a decision for the patient. Oh, they're just not going to want to do this. I think a lot of people, I think the main reason they come to doctors is they want to live. They want to be able to live their life. And if, they go through surgery, they go through chemo, they go through radiation, that's all things that requires a lifestyle adjustment. This requires a lifestyle adjustment. It doesn't have the toxicity of chemotherapy, and we'll talk a little bit about the toxicity, but it doesn't cause you to throw up, doesn't drop your blood counts. It doesn't cause the toxicity of radiation too, with the fatigue and things like that. So I tell people, in the end, what happens is you do it yourself at home, so you have control of it. And I think a lot of what happens when people are given the diagnosis of cancer is they lose control of who they are. And when they can gain that control back and do this themselves at home, the technician comes to their house, helps them set it up. It just makes all the world of difference. And I think they understand that, and they feel more empowered about themselves. And then I wanted to show the dose response curve. So if something is working, the more you use it, the more survival benefit you should see. And this is basically the dose response curve. The inflection point was at 50%. That's when you excluded the 1 for the hazard ratio. And you can see the more you use it, if you use it 75% of the time, you had a greater reduction in the hazard ratio. And if you use it 90% of the time, there's more. So these are the people that are really using it like 21, 22 hours a day. And you can see also in the survival, the overall survival, there was a very nice reduction of the hazard ratio. With the more you used it, the better you did. And I thought that was a very nice independent verification that this device works. And then what was really interesting was there in the trial, 450 people essentially were randomized to the treatment arm. 43 or about 10% decided if we're going to use this thing, we're going to use it like 90. We're just going to wear it. And what was so interesting about this was that when those people were analyzed, their 5-year survival was 30%. Nobody has ever seen that before with a GBM. In the end of the day, a GBM is unfortunately still today a lethal diagnosis, and the disease loves to come back. And to get a 30% 5-year survival, this is not a fluke. This is not some sort of weird placebo effect. This is a disease that will kill you, as you can see, unfortunately, in some of our great political figures of the last 10 to 20 years. So as we go into here, this is like the Tumor Treating Fields, the monotherapy and recurrent GBMs. This was the recurrent trial, and I just want to say this was looking at, it became FDA approved, the EF11 study, not because of survival advantage, but because of it was just as good as any chemotherapy that we're giving, but with less side effects. So the BSC was the control arm, best standard chemotherapy, and here was the Tumor Treating Fields. That there was, in the commercial setting, you can sort of see that there was an extended survival even in those patients too as well. And so that was sort of also suggesting that there was some long-term benefit for a subgroup of patients. And that I think that all of us have seen now in the commercial setting too as well. They're looking at it in brain metastasis. So lung cancer loves to go to the brain. 60% of your blood supply from your lungs goes to the brain. The brain is very greedy for energy and oxygen because, it's a highly metabolic organ. The rest of your body only gets 40% of the blood supply. So the first place, the blood, when after it's oxygenated after the lung, goes right to the brain. So if you have lung cancer, the first place lung cancer goes into the brain. So we have the Brain Mets trial actually open at Tufts Medical Center, where we're looking at after somebody presents with brain mets. We'll do initial treatment, of course, maybe initial radiation, but some of those patients are going to be randomized to the Tumor Treating Fields to see if we can prevent future brain metastasis from taking seed. Very cool idea. Maybe hopefully will prevent the need for further radiation, further surgery to patients with brain metastasis from lung cancer in the future. They're looking at other trials too for melanoma brain metastasis, combining it with immunotherapy. They're looking at small cell lung cancer because small cell lung cancer is notorious for going to the brain to the point where we give prophylactic cranial radiation even if before we even see evidence of any brain metastasis on MRI imaging. And then they're trying to also combine it with other types of immunotherapy, pembrolizumab, and also for the Nivo and Ipi for melanoma. And let me just go briefly about this. This is their other big success story. So I tell everybody, they're 3 for 3 currently for FDA approval for their clinical trials. They have FDA approval for recurrent setting for GBMs, newly diagnosed GBMs, and then this is their third trial that just recently got reported in 2019 with solid tumors in the systemically, which is a malignant pleural mesothelioma. These are very refractory tumors with very poor prognosis. Unfortunately, they're also very rare. And it's, as people know, this is strongly linked to asbestosis exposure. And this is what it looks like, So in some ways, you can kind of even hide it a little bit better. You can put it on your chest. So what they did was, obviously this unresectable mesothelioma, candidate for curative therapy, and they were looking at overall survival. And they combined it, the Tumor Treating Fields, with pemetrexed and cisplatin or carboplatin, which is considered to be basically the standard of care for this disease process, versus, just using, and then doing that for up to 6 cycles, and then just doing Tumor Treating Fields alone. And they compared this to basically, historical controls. And there were 80 patients in this trial. And this was the efficacy. And when they looked at this, the median overall survival was 18. I'm going to show you a slide where it shows the historical controls. But the one trial they compared it to, which was the pemetrexed plus cisplatin and carboplatin, that was about 12 months. So it improved the median overall survival when compared to the historical control by about 6 months. And it also improved the 1-year overall survival to 62%, which was a big bump here too as well. And I'll just show that too as well, the slides, when you start looking at it. So again, this was 80 patients, they had a good chunk of the patients being these epithelial. This was the direct comparison here, the pemetrexed cisplatin trial, and you can see it went from 12 months to about 18 months, and an improvement of the immediate progression-free survival too as well. And so just looking at the safety data, again, the main safety data tends to be there's some skin-related toxicity, and about a half, and this is what we saw in the GBM trial too as well, about half of the patients had a skin-related toxicity, and with most of it being grade 1 and grade 2, but 5% did have a grade 3 skin toxicity. And there was really otherwise no serious adverse events that were related to the Tumor Treating Fields. And they tried to keep the compliance to 75%, but the median compliance was 68%. So you can get an idea that, again, the more you use it, the better you do. That if you used it more than the 68, maybe if these patients had gone up to 90% too, as well as some of the GBM patients did, we might have even seen a better survival. And so let me just talk, they're trying this now in non-small cell lung cancer. We have this trial open up, the phase 3 trial that I'll show you in just a sec. But they did this trial, a phase 1/2 trial, and interestingly enough, they combined it with pemetrexed, and the median survival went up from 13.8 months to about 8.2 months. So they have this phase 3 randomized lunar trial, which we have open to as well. And they're doing it in second line setting, progression on or after platinum base. 500 patients are going to be randomized. And they're going to be doing tumor treating fields with a checkpoint inhibitor and chemotherapy. And they're going to randomize to just by itself, the immunotherapy, and then try and take a look. So that's overall ongoing. And again, primary endpoint is overall survival. And if you just want to look at what people are doing, I mean, I used to laugh and say, you know what, GBMs are now doing better than stage 4 lung cancer. But I have to say that it's no longer, they're really catching up to us. They have the checkpoint inhibitors now. They're having a lot more targeted therapies, with osimertinib being one of these sort of third generation EGFR inhibitors that can penetrate to the brain and the spinal fluid. And if anybody told me 2-3 years ago that we're going to be treating brain mets from lung cancer, leptomeningeal disease, where the lung cancer gets into the spinal fluid, if we were going to be treating that with a pill a day, I would have said, oh, you're crazy. But we are now, and some of these people have very extended survival with very minimal side effects. So really, this has been a big game changer in lung cancer. I'm very excited that we're going to be perhaps part of a trial that's going to perhaps add on to those overall survivals by adding on electrical field therapy to the lung cancer treatments. This was another one, so they have this phase 3 going on with a pancreatic cancer too as well. And, again, newly diagnosed, good performance status, again, about 500 patients that are going to be randomized. This trial is actually open and accruing, tumor treating fields, plus, the standard treatments versus just the standard treatments by itself. And, the phase 2 trial was actually reported in Europe, and it did appear to be safe and effective too. So hopefully that'll get confirmed in the phase 3 setting. And then they're doing for ovarian cancer too as well. So this was a single arm phase 2 where you look at the historical controls. It was about, as if people know, ovarian cancer, unfortunately, has a very poor survival. But here you can see that this more than doubled the progression-free survival, and the overall survival, as you can see, has just not been reached yet. The median is down here and it has not been reached. And where you pick, 61% of these ladies are living out 1 year or more. So amazing stuff. And hopefully, when they do the phase 3, that's which is now accruing, that's going to also show a very nice improvement of survival. But here it is again, about 500 patients. Again, this is just a 1-to-1 simple randomized trial. Tumor treating fields plus weekly paclitaxel versus weekly paclitaxels, and then following for survival and progressive disease. All right, and then this other one, now they're just now starting a phase 2 trial in gastric cancer too as well. This was the cell cultures, sort of data that they had back here, where you look at the gastric cell cancer lines, you can see improved survival. I'm sorry, survival, but improved toxicity in the gastric cell cancer cell lines, combining tumor treating fields. So now they're doing the phase 2 pilot design, where they're looking at the tumor treating fields. Remember again, 150 kilohertz to protect the normal intestine, which is 50 kilohertz, plus Zelox chemotherapy, which is sort of the standard of care for gastric cancer. And this is just phase 2, so they're looking at about 30 patients and just doing the treatment with the Zelox, and then of course looking at historical controls and seeing how patients are doing. And if they get a signal here, they'll move forward with a phase 3 on that too as well. So, and then there's a liver cancer too as well. They are doing the phase 2 right now for that too as well. Again, about 25 patients doing sorafenib plus the tumor treating fields, and then following till progressive disease too. And so again, in this sort of case, it's the primary endpoint is going to be the radiological response too as well, but they are going to look at progression-free survival and octave survival. And this is active, and it's not recruiting at this point. Okay, and I just wanted to take a look and see, this again. I mean, cancer treatment in the last 10 years has just boomed, and the targeted therapies, this really, I think, is the wave of the future. We're going to be looking at people's, we're going to be doing next-gen sequencing of people's tumor tissue and trying to do personalized medicine and gear and gear treatment toward this. Checkpoint inhibitors are really coming out. They're really, they're showing that they're improving survival, and there are some toxicities with it, which I think we're gonna have to figure out how to control some of that. But definitely an improvement of survival in multiple tissue types. So, before, we go on to the next section, we'd like to address some sort of audience questions that have come in. And one of those questions that have come in is, can you explain how healthy brain cells don't get affected by the tumor treating fields? And I think I did spend a little bit of time on this, and I want to emphasize that generally everything in the brain is at G0 arrest. They're quiescent. They are not trying to undergo mitosis. They're not trying to divide. So those cells do not get bothered by electrical fields. It's only the cells that are attempting to divide, that are attempting to undergo mitosis, that are trying to basically rev up these proteins that cause the formation of microtubules and that drag the DNA to the middle of the cell. And then those proteins that try and form the cleavage furrow, those are the ones that get affected, and then the cell does not end up being able to do that. So that ends up having a doubling of the DNA, which is a lethal dose to cell, which ends up going to apoptosis and dies. So healthy cells are not affected if they stay in G0 arrest. And then, Maddie, another question seems to have come to you. I don't know if you'd like to jump in here too as well. There are a lot of exciting trials. As a nurse, how do you educate your patients maybe on enrolling in open clinical trials?
So I think the most important thing is getting to know your patients and understanding what they're open to and presenting them with all of the options that they have. Some people have different expectations of what they want their life to look like, and making sure that they're not making any sacrifices to the time that they have. And thankfully, I have a great group of Dr. J. Pollan and other research coordinators that help make sure that we're able to introduce trials that our patients do qualify for.
And I find that, we get dragged away as physicians to so many different little things that have really nothing to do sometimes with in some ways, the health of the patient, like how they're doing emotionally and stuff. And I really feel, Maddie, that as the nurse, you're the person that can help guide me as well as guide the patient, like, how they're doing, what you think they can tolerate. Do you feel that that's something that more nurses should be really doing, for the physicians? And trying to educate them?
I think that's one of our biggest roles as a nurse, whether you're an RN or an NP, is understanding that we're there to help our patients adjust to their disease and helping them, looking at them as a whole and looking at all of their treatment options and getting to know them over time. Thankfully, I get to spend a lot more time with them than you do sometimes with how busy you are. So I think that I get this great look into their lives and able to help them kind of guide what I think they would be able to tolerate and understand what their wishes are and their beliefs and that as well.
And I think I find that very useful too, because people will sometimes say things to me because they don't want to please their doctor, right? But I think they're sometimes more candid with what they think I think you, Maddie, and so I think that nurse-patient bond is just amazing, and I'm always impressed by it too as well. Also, as a nurse, so part of it is like you're trying to explain this sort of this crazy idea, right? That you're going to wear this kind of cap on your head, right? It sounds like from a bad 1950s movie. How do you introduce and educate patients with this as an option?
So usually you will introduce it, at their first visit when they're diagnosed with the GBM, and we ask them to go and look at the website that gives great videos of the TT fields and gives a lot of information. And then during one of their radiation visits, I usually will bring in my model head of what it looks like and the bag, and I kind of present it as, with a little disclaimer, I know that this looks crazy. And because it isn't what they expect when they are told that they have cancer and they're told that they have a brain tumor. And it doesn't look, you don't see a lot of people wearing it. So it is a little jolting in that way. But then I begin to talk about breaking down what the device is, how you will care for it at home, what other patients do. And I find the information that other patients tell me about how they've adjusted their life to use the TT fields, that is really the information that I'm giving to patients that are interested in the device. And I also always tell them, give it a try. If you don't like it or you don't find that you can make this work in your life, then that's fine. But I suggest that they at least try it for a little while to see how it works for them.
I think, one of the nice things about it, because when we start our conversation with the patient, they start doing their 6 weeks of, chemo and radiation, and then they have the month off, and they really don't need to start the device, for another. So we have like 2 to 3 months to sort of talk to patients about it. What do you feel like what are some of the things that kind of really, maybe is a barrier or something that you can help them with during that time to get them to gradually understand maybe this and be maybe somewhat more open to the idea?
Yeah, I think the biggest thing is, getting to know them and understand their understanding of the disease, unfortunately their prognosis, and really getting to look at if they've done the research about the device, if they feel that this is something that, if they have a caretaker or someone that can help them with the device. And I also find getting the caretaker involved and asking them to also do their research really does make a big difference. As we find most of our patients do this as a team, whether it's with their spouse, with their child, a friend, a VNA. We have VNAs that will also do this for our patients, that they are the big people that really help us kind of guide the patient to make this decision as well.
So now I'm going to turn it over to Maddie to start taking about some of the practical nursing considerations.
Yeah, so my name's Madeline Couch. I am Dr. J. Pollin's nurse practitioner. We work together at Tufts in the Department of Hematology and Oncology. So the implications for nursing practice, as I said, as nurses, we're helping our patients adjust to their disease. And so the increasing use of these in cancer treatment really shows that it gives us another role as nurses, that we can really help our patients use this unique therapy because it really is unlike any other treatments that we're giving to our patients. I really serve my patients as an educator and an advocate because I want to help them understand the device and really help them incorporate it into their daily life. So some of the nursing goals are, at first initiating the treatment. I help them adjust to the daily challenges. And like I said before, I really use all of the tricks of the trade that my other patients give me of how they've adjusted to it that help me guide other patients in the same way. I make sure that I'm available to manage adverse events, such as some of the toxicities that we will talk about. And because I get the usage reports sent directly to me, that I can help them optimize their adherence with the treatment. And the usage reports really show us which days they used it, how much of the day they used it for, and the texts that come to their home also help go through any alarms or any error messages that come up on the device itself. So it has the battery and the arrays, and they're all connected with this long wire. And all the studies show us that the more that they use the TT Fields device, the better that they do. The placement of the arrays is important. As Dr. J. Pollin discussed, there is a standard layout, or we can target different areas of the brain to the tumor itself. And that Dr. J. Pollin decides based on the patient, based on where the tumor is, and their adherence to the treatment. So this is what the array looks like. And so all of the discs are all connected with this flexible circuit board. We have people with all different shaped heads, and after their surgery, sometimes there's a scar, or maybe there's some scar tissue left over that creates some sort of lump or, little change in how their scalp was. So it is very flexible. The bandage connects all of the arrays together, and 4 of them are arranged on the patient's head. So the only really common TT Fields related adverse event was the dermatitis. So about 50% of the patients did have the dermatologic adverse events. It was only a grade 1 to grade 2 dermatitis, and about 50 grade 3 unfortunately happened in about 6%, and about 7% complained about a lot of itching. So these were managed using published guidelines, and they all were fully resolved in all of the cases. So see, here's some of the biggest things that we see, and as the nurse, that these are the things that my patients come to tell me about, and all of these are all the different things that I help them manage. So one is the excess sweating, and in the summertime this is a really big problem for us, mostly related to how hot it is. We do have patients that like to exercise with their arrays on, which can also cause some issues, and then some people are just more prone because of genetics. Another is the itching that can happen, and that unfortunately is with the humidity and the temperature, along sometimes other medications can cause it. The contact dermatitis is, I believe, what we deal with the most, and some people are more sensitive to the hydrogel than others. The skin erosion is when part of the skin, unfortunately, is eroded off due to the device. And sometimes we can see some skin and soft tissue infections as a result of the arrays. So when we first prescribe the device, we like to identify any sort of risk factors that our patients may experience later down with the use of the device. So most have had craniotomies or at least biopsies of their tumor. So there is scar tissue, there is an open wound sometimes, and that's something that we have to take into consideration, as that area of their scalp can be more sensitive than others. Then some people have pre-existing skin conditions with a lot of sweating or any sort of alopecia, psoriasis, all sorts of different things. Then the other treatments that we're also giving the patients, such as the temozolomide, the bevacizumab, a lot of the time they are on corticosteroids and sometimes oral antibiotics as well. So these can also be associated with the adverse events. The neutropenia and the thrombocytopenia that comes with the temozolomide can also increase their risk of secondary infections from the device, along with an increased bleeding risk. The bevacizumab may increase the likelihood of wound breakdown if a wound occurs, and it may impair some of the healing that happens afterwards. So Dr. J. Paulin and I will assess their scalps every other month when they come in for their brain MRIs, as they can't wear the device in the machine. So it's a perfect time because people like to shave their heads right before they put their device back on. So this gives us, they usually will take it off the morning of, so they have a nice clean head. It hasn't been bothered by the razor. They haven't put any of the barrier on their skin, so we get a really great look at what their scalp looks like. So in preparing my patients and using the device, I give them a few prophylactic interventions to use. First is when they're shaving their heads, they need to make sure that they have a nice close shave before they apply the arrays. If they have any sort of hair left over, that can cause an error message and it'll cause the machine to beep, which drives everyone crazy. So we like to make sure that they have a nice close shave. There are a few different razors that they can use. There's things like using shaving cream and making sure that they have someone to really help make sure their whole head gets shaved evenly. We need to make sure that all of the natural oils and any moisture or sweat from the scalp is removed before they put the arrays on. The TT Field suggests using alcohol on a cotton ball to make sure the scalp is nice and clean. That can be very irritating to people. So we suggest using a mild shampoo once they shave their heads. That can help kind of clean it off as well. And making sure that their scalp is completely dry, even just using a cotton ball soaked in water can help pull off any extra hair that has come off when they shaved their head. Another is careful application and removal of the arrays. And this, I think, is one of the biggest irritants, is when they actually take the arrays off. And what we suggest people do is disconnect the device. All of the wires are unplugged. They get into the shower with nice hot water. We suggest using mineral oil or coconut oil to massage into the arrays. And usually by the end of their shower, the arrays will just slide right off their head, so none of them are pulling on their scalp, causing any more irritation. And then regular array repositioning. Some areas will get more irritated than others. Why? I'm not completely sure, but making sure that the caretaker is looking at their scalp regularly and repositioning the arrays to offset any sort of irritation that exists. We like to tell them to move it about 2 centimeters. Everybody's a little bit different. And then covering up the arrays, making sure that they're not putting something over them that is too hot, because that will cause a heat alarm as well. So in the patient visits, if they start to have any skin issues, we try to see them every 2 weeks if that's something that happens. We also get to use things like telemedicine to help us look at their scalp, and they will email me pictures so we can add it into their chart and kind of help them from afar. We do, like I mentioned before, on their MRI days, they don't wear their device, so we are able to see their scalp at that time. And I like to be really direct with the patients, and I thankfully get to know them well and get to know their lifestyle. So I know if some of our patients, for example, one will disconnect his arrays when he goes for a run. He'll go for a run with his wires tucked up in his hat. When he comes back, he'll plug it back in once he's stopped sweating, and that usually will eliminate any alarms or any issues that occur. I encourage them. I try to make myself as available as possible to either send me an email, give me a call, let me know any issues that you're having, and I'll help them troubleshoot.
Yeah, so thanks, Maddie. That was great. It's actually fabulous, and to see, how the integration of the patient themselves into this kind of care process, I think, is very important. So one of the first complaints we get, especially in summertime in New England area, I have to say in the wintertime, they kind of like this, because it kind of heats up their head, and we have a main patient that just wears it and says he doesn't even have to wear a hat. But in the summertime, unfortunately, it can cause a lot of sweating. So what do you talk to them, Maddie, about that? What do you tell them to do to help them prevent that? And this is just a typical picture that you folks can see in the audience of what it looks like.
So typically what I'll tell them to do is avoid direct sunlight, which can be difficult at times. We ask them to wear a hat that is breathable so they can get some airflow across the arrays. And like I mentioned with the previous patient, if they're going out and doing any sort of exercise for a short period of time or a period of the day where they know that they'll be sweating, they will disconnect their arrays for a short period of time and let it all dry before they reconnect it. We also suggest using an aluminum chloride antiperspirant, and we suggest putting it on the areas that they find they are the most sweaty. So sometimes at the back of the neck or across the forehead before they put their arrays on can help eliminate some of the sweating.
I think when I spoke to one of the pharmacists about that, the whole idea about putting on the antiperspirant is that you want to plug up the pores. So it's sort of the last step that you do before you let it dry, roll it on, then let it dry, and then put on the array so that the pores are all plugged up so that, the perspiration doesn't happen. Another thing that happens is, of course, some patients do feel that it's itchy or that they're noticing flaky skin. So there's, Maddie, what do you tell them when they talk to you about that?
So when people complain of the itching, I first make sure that they are washing their heads with a really mild shampoo. Sometimes using an anti-dandruff shampoo can really make a difference. Sometimes people also will just use coconut oil or mineral oil to wash their heads. They don't really need any shampoo as they don't have any hair. Then when they're preparing their head for the array placement, avoiding the alcohol products. So just using a wet washcloth or cotton ball to clean all of the hair off of their head once it's shaved can usually help avoid some drying, which will also cause some itching.
Thanks, Maddie. So next one is the contact dermatitis, and this really is the reaction to the strips itself, as you can see from the picture. And what do you tell? I mean, when we see these patients in our in our clinic rooms, how do you sort of address that?
So I like to really try to make sure I have plenty of pictures of what they experience when the caregiver is shaving their head or changing the arrays. Like I said previously, I think the biggest issue is removing the arrays. That can cause a lot of irritation and this kind of almost burn-like picture here. So we also sometimes will prescribe some topical corticosteroids using different barriers to help. And sometimes the irritant is the tape itself. So on the discs itself, as long as the discs are attached to their scalp, the device is working. Many people will cut the tape down to the discs and just secure it with the hat or the cap that they wear to avoid having any of the excess tape on their scalp.
Great. And another thing that we do have like ointments and lotions that we can prescribe. That's actually in the paper that's referenced there below. I was one of the co-authors of this, but we partnered with one of the dermatologists in Memorial Sloan Kettering, whose whole career has been built on the dermatological side effects of cancer-related treatments, whether that's radiation-targeted therapies, or in this case, electrical field, tumor treating field therapy. And so, if you're interested in learning more about it, I'd reference that article that was literally just published here in July. And then, sometimes, we see these, which we get much more worried about, that you get these erosions and ulcerations that happen. And can you sort of take them through the picture, Maddie, and say what you think when you see this, trying to find out what's going on with the patient and stuff?
Yeah. When something this severe happens, it usually makes me think that it didn't just pop up one morning. I want to make sure that they are changing their arrays regularly, making sure that they're doing the proper skincare to avoid this building up and happening over time. But whenever this happens, we tell them to just remove the arrays completely. That if the area can be avoided, usually it can't. So sometimes they just have to take the device off altogether. We will dress the wound should it need dressing. We also have great dermatologists that we can refer people to that can kind of help us with these wounds. We will give topical antibiotics, and we will also make sure that we follow up closely with them when this happens. Sometimes we will give them a treatment break with the device and with the temozolomide should the wound be significant.
And one thing that was very interesting that Dr. Lecoutre told me that is the scalp is really the hardiest part of your skin. It's a very hardy and very tough type of skin. So a treatment break sometimes can surprisingly yield a very good result too as well. So, and in the original trial, the EF-14 trial, which I was an investigator on, they would give like a couple-day break every month to patients just so they could go to a wedding, something like that. That was built into the trial, and that was totally okay. And if you realize this is like something we're trying to tell people to do over 2 years, and we're looking at usages over a month, so treatment breaks are totally acceptable, and I'll encourage that, especially because we want to preserve the skin, because that's going to be our way of trying to give the device. And then the last, one of the last ones is the dermatitis. This unfortunately can happen too as well, or and sometimes with infections too. And you can see this kind of nasty looking, kind of like this inflammation, and sometimes there's again this pus, itching or burning, and again, Maddie, when you see this, what do you talk to about the patients, and how do you educate them about this?
So I go back to making sure that they're taking care of their skin the right way with how they're removing the arrays, how they're cleaning their heads, how often they're changing them. Sometimes we'll prescribe some topical antibiotics, also suggest warm compresses to help alleviate some of that. We have taken wound cultures in the past, and we do have wonderful dermatologists that help us with these as well. And again, we keep close eye on them, whether they come back to see us in clinic or they just send us pictures, and we use telemedicine as a way of keeping a close eye on it.
Oh, great. I think that makes perfect sense. So I think just, to kind of conclude, the use of tumor treating fields, I really think is a very, and I actually, even though people call it a choice, I said, it's people are coming to you for their care, and say, oh, you can choose to have surgery or not have surgery, or you can choose to have radiation, or you can choose to have chemotherapy. I think if you explain to this that this is something that gives you survival advantage and put it in the same context that you do everything else, I think people understand. And at the end of the day, if they didn't want to do anything, they would have selected hospice in the beginning. And they're coming to you to trying to maximize their quality of life, which can happen with this, but also maximize the quantity of life, which can happen with this treatment strategy. So I really do try and emphasize that to it's how you approach something and present it to patients, and then make them realize that other patients have done this too, and they can actually tolerate it quite well, incorporate it into their daily lifestyle, and have a very good result, which is, improved survival and quality of life. And, we also emphasize that you have to wear it at least 18 hours a day, because there's no half-life. You turn it off, it's not working. I think I can't emphasize enough at how much I rely on Maddie in the clinic to help these patients out. We're trying to get palliative care also. That's our palliative care group, which is more inpatient, is now going more outpatient too. And I think I want to try and get them involved too, to help out with some of these side effects and things, so that we can try and educate patients about this. And I really think that I can't emphasize enough about, this is a fabulous new treatment modality. It can be used constantly. I think it can help suppress these quiescent cells that and keep them quiescent, so that we can increase long-term survival. And I want to thank you for your attention, and have a good day.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.